Assalamu alaikum and good morning, everyone. Firstly, thank you very much for inviting me. Really honor for me and privilege for me. Second time I'm here. And, and secondly, congratulations. I think it's a great endeavor, an effort to take such initiative. And we all know that in the recent times, especially in my own profession, we really feel blessed that we are in a time when we can do something about hearing. And as we all know, basically, your sensory organs are very important for your basic survival. If you see in the nature, you need your two special sensory organs, eyesight and hearing, for your survival. And statistically, if you compare both of these, it's known that hearing is more important than even vision. Therefore, having such an endeavor where we can do something to restore such sensory organs is very satisfying. And congratulations for that. And I'm really honored to be here and privileged. I'm not sure. Dr. Sadaf spoke to me that what should I say here and what's the experience you got. I just, as Professor said in his very nice talk, thank you, really enjoyed it, that you have to go through a very simple process as any other clinical intervention, especially when you're surgical intervention. You have pre-op protocols, you have operative skills and procedure to follow, and then you have post-op care. And then obviously in such situation where you have a constant care through the rehab process, not everything goes as smoothly. And every patient is unique, every patient is different, and you have to adjust accordingly. And obviously you see certain problems, certain issues, and I'll try to just simplify these things and what you encounter in pre-op time, different types of patients, operatively, what sort of problem you can face generally, and how you handle them. And firstly, it's well established. We are doing this, I think they started in 70s when they started this single channel implant in Mayo Institute, and then it was late 80s and early 90s when they went to multi-channel implant, and we have more than 30 years experience, and it's pretty safe procedure. You can reassure the patients, their parents, that this intervention is safe for a child, for an adult. It is come within a safety where the risk of complications is very low, and there's a more than 90% chance that they will get benefit for whatever we are aiming for. Therefore, it's reproducible, it's a safe intervention, and as Professor said, that it's a multidisciplinary team setup. You have to go through the process whereby you have to observe the protocols and make sure that before you do such an intervention, your selection process is robust and you don't end up in a problem. You see, children, it's okay, you have a healthy, normal kid, you assess them, they fall within criteria, and you recommend them to a cochlear implant. But when you see there are kids with special needs, there are kids who have learning disabilities, there are kids who have delayed milestones, it's difficult to condition them, difficult to, even assess them hearing wise. And then the question arises that if we do the intervention, are they going to go through the process of rehabilitation? And these things need to be addressed before you start anything. Therefore, as this is part of the multi-MDT, that you make sure that when you advise intervention, you are within a safety net, that this child is going to use the implant and is going to get benefit. Now, operation itself it went through over the years. People have tried different ways and means, different techniques, and now all over the world the technique is quite standardized and it's safe. On average, takes 1 hour or 2 for surgical intervention, and then a lot of center, in my center, if we do in the morning, we send the patient home by the evening, and it's not a maximum overnight stay in the hospital. And procedure itself, standard these days, these are my old slides, and I intentionally put these, that we used to have a different scenes initially. I remember we used to have a end scene extending backwards, raising big flap. This was surgical police. Now we've gone slightly post-slightly, extended post-slightly. Now we do minimum access surgery. It's about 5 centimeter post-RNC, and with that access, you can manage very well. The access approach is very straightforward. The main idea of surgery is that you want to put the implant inside the cochlea, and whatever we do is just access to cochlea. For that, the standard technique is that we do cortical mastodectomy. My colleagues who are not surgeons, which means that you remove this bony cover over the mastoid area and clear all the cells so that you can get a back part inner ear view, which is labyrinth. Here you see the lateral sensory canal. And then from there, you make an access from mastoid area to the middle ear, and the deep part or medial part of middle ear, your inner ear, cochlea. And the technique which is developed is called posterior tympanotomy. As we know in surgical field, you have laparotomy. Similarly, there is tympanotomy, mean that you access to middle ear space from behind. The idea is that you don't disturb the skin in the outer ear canal. Make sure that cochlear implant stays within the bony boundaries. There is no access to soft tissue. People tried different ways. So the children, some have different anatomy. They have tried to drill small grooves inside the ear canal. They tried different techniques, which is with a small tunnel through here. But those kids, over the years, they have more complications. They end up having extrusion of implants, the electrodes coming through the skin. Soft tissue breaks down under foreign bodies. So the idea behind with this technique is that we must have a bony cover. The most of the implant should be within the bony confinement. This is the cortical mastodectomy. You clear all the mastoid ear cells so that you can see the part of inner ear posteriorly. Then you make an access to middle ear from behind. It's a technical thing from a surgical colleague. It's a space which we have just outside the facial nerve and deep to the eardrum. And the landmark we use is chorda tympani. If you do middle ear surgery, chorda tympani runs next to the annulus. And if you stay between those two places, you have enough space for you to have access to cochlea. The tips are that if this mastoid is healthy, it's cellular, nice formed, it's very easy. It takes 5 minutes to access there. The problem happens, I'll show you different slides, when anatomy is not as simple as you think. I have seen kids, there's no mastoid development, there's no air cell at all. Due to chronic inflammation or eustachian tube dysfunction, they have a totally sclerosed mastoid. The dura can be very low, the segment sinus here. There's a bony, for people who are not surgical side, there's a big venous structures which drain the blood from cranial cavity down to the neck, and they come through, there's a sinus there which drains down there, sorry, just flicks down the back, which drains through jugular bulb, and all these are very in close proximity to the inner ear we're operating. And you can come across this big sinus here in the cavity itself. I've seen sinus coming and touching where you're doing the posterior tympanotomy, and then in the middle ear itself, you can have a distant jugular bulb, a jugular bulb coming and covering the round window or the area of cochlea where you want to put the implant, and how to deal with these things. That's the standard technique. It's a standard picture. I took it, and you have that's the cortical, and then you create this space from behind, which is between the facial nerve here and chorda tympani here, and then in the middle you see the cochlea, you see the oval window with stapes there, and then you see inferiorly round window, and that's the area where you want to put the electrodes in, through the round window into scala tympani. The scala tympani is easily accessible from there, and it's the broader area in terms of accommodating the implant itself. And then you create a small area. These days we mainly use the periosteum pocket, or you can drill a bit of bone to stabilize it. Then you keep the electrodes inside the bony channel. If you don't drill this channel, there will be muscles over it, and each time muscle will contract, it will cause pull and push over the electrodes. And potentially, because if you see these electrode array under microscope, depending on who the manufacturers are, you can have a 22 or 12 or 8 channels running through this small cable. And if you see them under microscope individually, these are thinner than your hair. And if you leave it exposed and muscles contract, potentially they can cause microfractures, and you can have a slow failure. And it's important that keep them within the bony channel so that there's no risk to excessive trauma either by outside force or by the muscle contractions. Okay. And post-operatively, you close the wound, make sure there's no hematoma. You put a bandage for overnight, take it out, secure the hemostasis. When you put the implant in, absolutely no diathermy. If you use diathermy, it can potentially cause the device. Monopolar, you can use it, try to avoid it. Monopolar is fine. But, sorry, bipolar is fine. Don't use monopolar. I repeat again, I was slip of tongue. Don't use monopolar diathermy. Bipolar is fine if you need to, but make sure you secure the hemostasis before you do it. Do the check X-rays after that device is in place. Because it's a blind insertion. You can put the electrodes through round window, and these days electrodes are very, very soft. I've seen that you do perfect insertions, it can turn back into the vestibule, it can go into the, if there is a other underlying condition, softening of bone, otosclerosis or osteogenesis imperfecta, they can go to wrong places. And check the X-rays afterwards, and make sure that there's no other risk of complications in terms of there's no leak of CSF or facial palsy. I'll show you the slides again. In terms of precautions, I think Professor Maimansab did mention afterwards the trauma, operating a battery, there will be repetition there. MR scan is an issue. I normally use this as a precaution when they come to see me, that is in terms of when you give the information package before the implant to the parents or the patient himself or herself, these issues are discussed. That modern implants, they all, it depends upon who are the manufacturers are. They are quite okay for 1.5 and sometimes 3 Tesla. But even then, we have to follow the guidelines by the manufacturers, should be discussed with the radiologist. We have a protocol when do the, and these days more and more people are coming because they're using the implant for 20 years, they develop other conditions, and they develop degeneration of the joints, fractures and other issues, and we're doing more and more MR scan now. We have a protocol there that in which we use this patty which you use for the hearing mold to make a mold over the implant and put a tight bandage under local anesthesia and do the MR scan and then remove the bandage. If there's no issue there, it's working fine. But rarely you still see that magnet get displaced with a strong field of magnetism in the MR room. And you have to inform the patient about it. Check the facial nerve. It should not happen, but these days still happen afterwards, one of the risks. And if it does happen, make sure you address to it. Professor Maiman did mention about gusher. When we do these surgeries, a lot of children, they have anomalies as well. I don't know whether it's the margins, but you have a condition called wide vestibule aqueduct, in which there's a more chance of gusher. You have Mondini's, in which they can have a quite open communication with the IAM, and these kids can have very profuse CSF gusher, and it can be really alarming. And you make sure that this kid has a, I hope I don't have a video with me, but she woke up with the CSF rhinorrhea on the same side, and patient should be informed. And there are special techniques when you do surgeries. If you preoperatively you identify these inner ear anomalies and you suspect CSF gusher, address to it, and you have to have a proper seal at the site of whatever you do, cochleostomy or round window insertion, and you plug the hypotympanic cells so that there's no chance of CSF leak. I put this one when we start doing the implant. Some kids, when some are doing surgery, you have long incision there, and they used to raise this flap to put the reference electrode. You can get a lot of bruising around the eyes. It's not cellulitis, avoid it. Therefore, in children, this tissue is very soft. So when you, my surgical colleague, when you raise this tissue, it still happens in my own hands as well, but make sure that you're very gentle, otherwise very easy that whole skin lifted up and you can end up quite a lot of bruising around the eye as well. The gravest thing which you all dread as a surgeon is the post-op infection, whatever you do, and especially when you're doing foreign body or device insertion infection is the worst news you can have as a surgeon, as a patient, as a carer. And the reason I said so, the moment you suspect, it's not antibiotic, the moment you suspect there's a risk of infection there, treat it as aggressively as you can. This is not something to be taken lightly. It's a grave emergency. If some kid is having redness or pain, see them straight away. Take them as an emergency and straight away should be put on IV antibiotics. That's the minimum chance you can give to the child or a patient to avoid a grave risk of extrusion or explantation. That's the gravest thing you can suspect, that inflammation or infection. And if skin breaks down, that's the worst news you can have. Over the years, we have few patients end up with this thing, and we try different things, repositioning the device, getting plastics involved, putting the flaps over them, and honestly, it doesn't work. Whatever you do, it does not work. Once you have biofilm around the implant, nothing works. Antibiotics, they don't penetrate that area. And unfortunately, here we have to take the device out. And what we do when we explant it, we don't take the whole electrode out of cochlea. My surgical colleague, the best tip is that cut the electrode at cochleostomy and leave the array inside the cochlea, remove rest of the device, treat aggressively, leave for a few months. I normally leave for 6 months or so. For us in the UK, it's easier because you have a bilateral implant, especially in children. In adults, it's different, and with the bilateral implant, the kids still have access to sound with the other side. Here, things are different because you have only one-sided, and unfortunately, that's where things are. We have option if there is no longevity of deafness, the child is not already 10, 11, then you may think of doing the implant. When you explant one side, do the implant on the other side. Otherwise, let the skin heal up, let the infection go clear, and then re-implant it. The other issue which we face is the sclerosed or ossified cochlea. I don't know what the situation here is. I don't remember now when was the last time I did in the UK drill out. Because with the meningitis, with the more awareness, with the vaccination, the kids are referred fast track. They are picked up very early stage, and we don't see very often ossified cochlea, but rarely you still see it. Again, if some kid has a meningitis, it's emergency. Don't leave them for months and months. See them as soon as possible. Statistically, you say that, there's about 35-40% chance of total deafness, but unfortunately, it's very difficult. Some kid is gone profound range within few months. He or she may recover in coming months, but which one is recover is very, very difficult. So this is a grave emergency. Some of the meningitis and deafness, see them fast track, do the MR scan. If deafness is confirmed, do cochlear implant ASAP before the lumen got obliterated. The reason is that once the cochlea got ossified, firstly, you can't predict the results. You do the drill out, how many, because it's a suppurative process. When you have a pus formation in the cochlea, and then you have a new fibrosis, new bone formation there, it's very difficult to predict that how much dendrites are survived, how much responses you get. And once even you got the responses, over the time you have seen that impedance goes up. Even the area where there's no bone over the dendrites, that got bone deformation as well. Therefore, it's not a good news for family, for the child, for adult who's have meningitis. Treat them before the things gone too bad. And the technique we use is drill out. You drill basal turn and second turn, and the landmark of my surgical colleague is that basal turn, obviously you drill the in front of round window area, and second is the second turn you get access just in front of the oval window area, just below the processus cochleariformis, and you put the special electrode which you need to request is a split electrode array, in which there are 2 electrodes array which are already split by the manufacturer, and you put one in this area in the basal and one in the second turn, and with the hope that it can cover the modulus and you get some responses there. And this is just to show that I think one of the this video is not going to play. I didn't have the video on this flash drive, but this is the case in which I just want to highlight that you may come across, people have done these days a global world, people have gone to other parts of the world, they got a surgery done by different surgeons, and this kid has this suprameatal approach technique, and the electrodes are here, and when I saw this child, the electrodes are lying in the ear canal, and it's not a good news, they're infected. Again, this kid needed explantation, wait for 6 months, and then redo the surgery through conventional approach. NF2s, I don't know how much NF2 you see here, but they are very, very special cases. We have, because here you delay the intervention as much as you can, because we know at the end of the day, they are young people, they will lose the hearing, and we have done some implants in these kids, although they have a tumor on this side, but even you buy 5, 6, 7 years, you can do the implant, and then once they got the tumor bad enough needing surgery, obviously you can't preserve hearing in them, and then they are the kids who are the major recipient of brainstem implant, ABIs. And make sure if you see them, you counsel them, you tell them about hearing. Cochlear implant is not a solution for them, and they need to be sent to a center where they have artery brainstem implant. We haven't done any brainstem implant in Pakistan yet. Therefore, you can counsel your parents, this facility is not available. It's not only you need to have a proper neurosurgical backup, special audiological training in terms of switch on and then mapping and then dealing with these kids. So far, we don't have that infrastructure here in Pakistan. Bony capsule itself, you still come across this. I'm sure you must be seeing a lot in here, otosclerosis, osteogenesis imperfecta. What happened that these patients have two problems. Otic capsule itself gone very spongy, very soft, and these days luckily we have a modern electrodes are very, very soft, but even then we still see that they can find a way through the bony capsule. I've seen the electrodes lying in the carotid canal. They can very easily slip into the IAM, and they can come through the capsule, deeper part of the anterior mesotympanum. Secondly, the lumen itself got a lot of fibrosis, new bone formation. It's very difficult to get the electrode through there, and these things need to be addressed preoperatively, need to be seen and addressed preoperatively. And in these cases again, the results could not be as promising as you think. Therefore, look for these things, make sure you have good friendship with your radiologist. They should pick up these things preoperatively. And if someone has a history of otosclerosis, and sometimes they don't come with the conductive loss, they have purely cochlear otosclerosis. They come with mostly sensory hearing loss, and you can be caught in there. And make sure you got, as Professor Iqbal said, that you do both CT and MR scan. I think this is a safe thing to do. If you do CT, you may miss it, but if you do MR scan as well, you will pick up the lumen obliteration. Missing nerve. This is the commonest thing we come across, that people who are not trained to report on MR scan, and obviously we are ENT surgeons, we do our best to pick up, but we can't pick every finding, and make sure that especially in young children who have no responses on ABR testing, that you have a good protocol to look IAM. You need to have two nerves here. Here you can see there's one nerve running here. As in one nerve running here, so normal facial nerve functions, most probably the eighth nerve is missing. And they are not for cochlear implant. They need to be referred to brainstem implant. This we covered it, ossified cochlea, and we should be aware of it. Inner ear anomalies is very alarming when we pick up and someone has a deafness and they said, oh, your ear is not formed. That's not contraindication to have a cochlear implant. Those kids can still have cochlear implant, but with some special precautions, and sometimes you need to request a custom-made electrode array for them. Common cavity, Mondini, short cochlea, you can have a compressed electrode array, you can have for the common cavity, a special electrode array which can go around with the hope that in these cases, if there's a like common cavity, a sphere Mondini, the problem here is that difficult to predict the way the dendrites are, how the cochlear nerve is distributed around the remaining cochlea, and you try to put the electrode array which can maximize the potential to get the neural innervation. Dysplasia we've gone through. I think and I mentioned in my earlier part of the talk that we should be aware of CSF gushers and the risk of meningitis, and the surgeon should be aware of and should know how to handle it. Common cavity wide vestibular aqueduct syndrome, we discussed it. This is the for my colleague who do surgery. Anatomical anomalies. Recently I have come across that totally absolutely no mastoid air cells. The sigmoid sinus was lying so forward, was lying touching the back wall of posterior canal wall, where you're going to posterior tympanotomy, and you need to have a special planning for these things. You may have to expose the dura, you have to expose the whole sigmoid sinus, and when you expose them, you take the bony covering out without touching it. And for my surgical colleague, to deal with these venous structure is that don't touch it with your instruments. That's the basic tip. Don't touch them with the instruments. You thin down eggshell the bone, you remove the bone, and then with the irrigation and Surgicel you can use bipolar to decompress it. And once you decompress it, in most cases you will find a space to posterior tympanotomy. There's only one case. I have not done anyone. I need to do the suprameatal or other approaches. I could do them even very close mastoid. There's only one case in which the facial nerve was very, very lateral. It was bifurcated and it was going so lateral, there was no way I could do the posterior tympanotomy, but there's no way you can access the cochlea. And in those cases, you can still feed the electrode through posterior tympanotomy, but for insertion, you can raise the tympanomeatal flap, do cochleostomy through anterior tympanotomy as you do styptotomy, and then you can do the insertion. Okay. Anatomical variation, tight mastoid, very prominent sigmoid sinus or high jugular bulb. Excuse me. You can decompress venous structures, removing the bony cover. You can decompress dura, and you will always find the space to do posterior tympanotomy. If it's too tight, there's no harm removing incus as well. You can remove the incus, and then from above, you get a bit of more space to visualize the cochlea. And thirdly, if you can't insert through the tight space and get the electrode feed through, you can raise tympanomeatal flap, do anterior tympanotomy, and you can insert the electrode ray in that way. I don't know how many cases you see here. Problem with CSOM is that I haven't dealt, I think only one case I did in 20 years in Pakistan was post-CSOM and needed cochlear implant. I don't know what's the theory or what's the reason behind it. Could be, firstly, that CSOM, we don't do many adults in Pakistan anyway. I don't know, it's a cultural thing. We ourselves, when we grow old, hearing is gone, we take it, and the way our social setup is, the way we take our social responsibilities in the family, adults don't feel like spending so much money on them, especially for their sensory things and for the health thing. I'm talking about general population. And secondly, CSOM is a disease of poor people. And I've seen only one case in my whole 20 years working in Pakistan was post-CSOM, but it's not like that other part of the world. This is a very special scenario. So what I want to give a message that these cases can be implanted, but with a special planning. In most cases, it's a two-stage procedure. You have to make the cavity infection-free, and when you put the implant, as I said earlier, it should be in the bony confinements, it should be isolated. With different options, you clear the disease and you obliterate the cavity by putting abdominal fat or whatever the way, wait for 6 months, go back, make sure cavity is infection-free, and you put the implant. It's a simple perforation. You graft the ear first, wait for 6 months, ear is healed up, it's dry, you can put the implant. There's only one case I had when I went there to do cholesteatoma. He was in the cochlear implant workup, and the clustered was halfway through in the basal turn of cochlea, and half of the basal turn already gone. And we felt that if we leave it, cochlea got ossified in 6 months or so. We did the primary implant surgery, but that person needed 2-3 revision surgery with the implant in. The cluster did come back every few months. Therefore, you can deal with the infection first, isolate, obliterate the cavity, fat obliteration, blind sac closure, graft the tympanic membrane defect as a second stage to the cochlear implantation. Scalp problem, I think I addressed already. If skin is broken down, in my opinion, nothing works. Flaps, plastic surgery, nothing works. You have to explant the device and do a second stage procedure.